So let's move on to our next point in our list of 5 interactions between climate and COVID. Climatic risks influence the transmission of COVID-19. Long-term exposure to air pollution is correlated with COVID-19 morbidity and mortality. So what this means is cities with more air pollution have a high number of COVID cases and a high number of COVID deaths. And this is consistent with results from hundreds of cities around the world. Air pollution is caused by airborne particulate matter, and most of the studies that I'm showing you here looked at PM2.5. Much of PM2.5 comes from fossil fuel combustion. So how does this particulate matter 2.5 impact COVID transmission? PM2.5 is an air pollutant that provides more particle surface for the virus to stick to. And as this PM2.5 moves through the air, the virus is attached to it and it can move longer distances. 2.5 marks the aerodynamic diameter of the particle. It just means it's small. And so it can be inhaled really deeply in our lungs. When we inhale the pollution, we also inhale the virus. And this was also shown in relation to air pollution in the 1918 influenza pandemic, as well as the 2002 SARS epidemic. One of the reasons why I want to highlight this for you is that the spatial distribution of PM2.5 is not even. It is socially structured. So take a look at this map. The spatial distribution of PM2.5 around the world. Outdoor air pollution causes 4.2 million premature deaths annually. And the World Health Organization tells us that 89% of these deaths occur in low and middle income nations. So my question for you is, why would there be more PM2.5 in low and middle income nations? What could explain this trend? This is about the economic positioning of these countries in the world system, basically, picking up on Wallerstein's world systems theory. And I want to introduce you to the concept of environmental load displacement, the process by which more developed, more powerful nations outsource their undesirable industries and environmental harms to less developed nations and gain access to additional resources to meet their disproportionately high levels of consumption. So we talked about the concept of environmental racism, which is where people with less political influence, lower income, and often racialized people end up living nearer to more hazardous waste sites and therefore living with higher rates of air pollution. So we can see this within Canada, but we can also see this on a global scale. And we can also think about the type of economic structure and technology in the countries, their debt to other nations that sort of forces them to participate in the economy in certain ways, and laws and regulations around the environment and labor. The third point that I would like to highlight is increased susceptibility to COVID-19 through wildfire smoke inhalation. So while COVID was happening, several massive wildfires also took place around the world. We had some in Canada, especially in BC. The US had them in California, Siberia, Turkey, and the Brazilian Amazon. And wildfire smoke also has this PM2.5 and is connected to increased morbidity from influenza. Forest fires have increased in recent years, partially due to climate change and rising temperatures, and partially due to settler colonial forest management practices. For thousands of years, First Nations peoples in Canada and other countries have practiced low-intensity controlled burning in the winter. And this removes dead materials from the forest, it activates dormant seeds and actually revitalizes the forest. And most importantly for us, it actually makes tree bark and other parts of the forest resistant to high-intensity fire. In 1874, the colonial government passed the Bushfire Act. in British Columbia, as well as other provinces. And this banned First Nations peoples from utilizing their expertise and engaging in fire stewardship. These fire stewardship practices are part of passing on intergenerational knowledge. And we need to change regulations and policies so that these practices can be more widely used. And I'm happy to share with you that there are a number of projects happening today, including in collaboration with UBC, where First Nations leaders and First Nations elders are actually working with industry, with government, and with researchers to share their expertise and be leaders on future fire and forage management practices. The fourth point is climate change and the mass displacement of people. So extreme weather events caused by climate change can lead to mass displacement of people in the form of evacuation, in the form of migration, and in the need for mass sheltering. So mass displacement can move diseases into new regions as people are moved. It can cluster survivors in temporary accommodation with little or no ventilation and with extreme heat. And it can also increase amounts of social contact, which makes social distancing extremely difficult. And so what this means is that mass displacement of people results in modified disease exposure. And mass displacement actually did occur during COVID for in many regions, including in India's eastern coastal states of Odisha and West Bengal, where they faced Cyclone Amphan in May 2020, so just a month after the pandemic was officially declared. So they're already dealing with COVID, and then thousands of coastal communities had to relocate to cyclone shelters that were crowded and made social distancing really challenging. And this mass displacement not only increased their health risk, but also had financial implications. Because people were moved, they couldn't continue their livelihood activities. And the cyclone destroyed some of the forests, which were part of how they made their livelihood.
So we're seeing all kinds of compounding vulnerability here. So overlapping crises. And the fifth point is sort of zooming out and thinking about the long-term impacts of climate change, the long-term creation of vulnerability over time, and how that can create increased pandemic risk. In one modeling study, Ozcan and colleagues showed that countries with high climatic risk also had higher COVID-19 mortality rates than countries with low or no climatic risk. So this leads to questions about vulnerability. Climate change can increase the three prongs of vulnerability that we've already talked about. Hazardousness of place. Regions can become more or less vulnerable as temperatures change, as sea level rises, for example. Built environment vulnerability. Climate disasters can negatively impact buildings and infrastructure, increasing built environment vulnerability. And social vulnerability. We know the social vulnerability is the social structuring of a group's capacity to anticipate, cope with, resist, and recover from the impact of a disaster. And this can change with climate change as well. So let's look at an example of how climate change increases vulnerability. Okay. As of July 2020, Peru had the most deaths due to COVID-19 relative to its population size. How did this happen? Peru's 2017 El Niño Costero event severely damaged 1,000 primary care centers from flooding. This represents an increase in built environment vulnerability. The direct effects of climate change damaged and undermined health and emergency response infrastructure. And when COVID happened, few of these health centers had been rebuilt in time. So pandemic planning and management was compromised. And this lack of pandemic response infrastructure was exacerbated by pre-existing social vulnerability. Peru's Amazon region was hit the worst from COVID. This region is home to 1/4 of Peru's low-income population. Indigenous peoples in the Peruvian Amazon are especially vulnerable to emerging health risks because only 30% have access to health facilities within their territory, and only 18% have access to public water services. Some Indigenous communities were also facing malnutrition due to climate impacts on their food systems. And when you are malnourished, you are more susceptible to the impacts of disease. 3, when COVID hit, it corresponded with the largest outbreak of dengue fever. Dengue is a climate-sensitive disease passed on by mosquitoes, and it increases in the rainy season with warmer temperatures, going back to the temperature point. Mosquito control activities like spraying were stopped during COVID lockdowns, so mosquito bites increased. People who came to a clinic were often misdiagnosed as having dengue when they had COVID.
Here's a quote from Ford and colleagues. For Indigenous people who have limited access to health services, the coexisting of dengue and COVID increase their susceptibility of being misdiagnosed and not receiving appropriate treatment. One of our community observers reported her experience with dengue and COVID in January 2021. She had to transport to the health post and then to the hospital because initially the health worker suspected dengue. He took a serological test and told her to come back in 15 days to get the results. The next day, she and her family got severe respiratory symptoms, and a posterior test confirmed that they all had COVID. The dengue test came back as negative.
So in sum, this example illustrates 3 factors shaping vulnerability: built environment vulnerability through healthcare infrastructure, social vulnerability through marginalization, and overlapping disease outbreaks.